minutes talking about rectal or endoanal ultrasound. Uh, Come on, the slides moving. So it's important to disclose that this is not a modality that I use a lot in my clinical practice for several reasons. I think the people who understand the pathology and anatomy very well are colorectal surgeons. They're the one who are actually dealing with the pathology, seeing a lot of patients and managing it, and have a better anatomical understanding. Another reason is what we have and what we've seen in most centers, that they have these transrectal ultrasounds, which does not require any endoscopic views, and they can perform the scan. Additionally, these days, the MRI actually has superseded rectal ultrasound EUS on many fronts. So that's one of the reasons we don't tend to utilize it. So what we're going to do is we're going to talk about rectum anatomy and of the anal canal. We'll talk about what scopes do we need, how do we prepare our patients, and what is the image orientation that we need to have in our head when we're actually when we're actually scanning the plane. So just to have this understanding. And then I think what we're going to we're going to divide it into rectum and anal canal, which hopefully will make some sense in terms of doing the rectal ultrasound scan. Now, one of the areas where we've seen a lot of expansion is EUS in inflammatory bowel disease. We've also had patients who presented with the cecal lesions where the endoscopist had to use a thin probe through the colonoscopic channel to visualize it. So there is an evolving field out there. So if a person does not have major pancreaticobiliary interest, or they're not kind of hepatologist or not a gastroenterologist with upper GI pathologies, and they have most interest in IBD, this is certainly a tool which is also of helpful to them. So you can be very useful to your oncological colleagues and also your colleagues who have interest in the inflammatory bowel disease. Yesterday we also talked about this three-dimensional ultrasound. So EUS is usually a two-dimensional modality, but obviously with the advancement in the technology, we are now looking at performing 3D endoscopic ultrasound. So if there is further advancement, then this is again an area where we may see some benefit that we can potentially offer to our patients, not only in IBD, but also sort of, that wasn't a B9, but B9 anorectal diseases. So, anatomy. Who among you consider that they've got a really good understanding of it? Okay, so I think just for the sake of the discussion here, we're going to just keep it very simple. Begins at the rectosigmoid at the level of S3 and then ends at the anorectal junction. Okay, then it's also important who you're actually scoping. Is it a male patient? Is it a female patient? Okay, because in the male you may have to orientate it slightly differently. What organs are interior and what organs are posterior. Now some colleagues will actually, when they're doing it, they can put a rubber band on the scope and can actually mark it so that you do not lose your orientation, especially when we're using the linear scope. So that orientation is incredibly useful because the relationships in female is going to be different with uterus, vagina, cervix coming in, and then if the appearance is going to look differently, so you actually do have to train your mind in that pattern recognition. Posteriorly, the sacrum and the coccyx would remain the same. So interior and posterior structures, ensuring the orientation and seeing is it a male or is it a female patient. Okay, so clear so far? So please feel free to interrupt me and we can sort of just talk it. The other thing you can do it, especially in the ultrasound, you can divide it into upper, middle, and lower third. Especially when you're then trying to assess the relationships laterally to the anorectum, because in the upper third you'll have this pararectal fossa with bowel, internal iliac vessels, and the uterine and fallopian tubes and ovaries in females. And in the middle one third is the pelvirectal space and levator ani, which is going to be the same whether it's a male or the female patients. And in the lower third, when we're actually coming toward the anal colon, you'll have this pelvirectal space with levator ani and obturator internal muscles, which again, as we know, should appear hypoechoic or darker as compared to the mucosa. So you all know the 4 or 5 layers that we look at when we're doing the esophageal ultrasound. What scope should we use when we're doing the rectal? So as I said again, I don't do a lot of them, and that may be the reason I do it. I would use both radial and linear scopes, just to get the orientation right. And again, I think given the advancements, we are more kind of focusing on the therapeutic side than the diagnostic side, given the advancements in the MRI scan. But again, remember those 5-layer concepts would remain the same. So there's a coupling of interface of the probe or the balloon with the mucosa, and then we've got the mucosa, submucosa, and then in that we've got a muscularis mucosae. So 2 black layers is your muscularis mucosae behind the bright layer of the submucosa. Then we've got the muscularis propria, which is also going to appear black. So 2 black layers, muscularis propria and muscularis mucosa and muscularis propria. So one thing to mention here is, as I said, what we want to do is, this is one situation where we may want to start with the radial EUS scope and then follow it up with the linear scope, especially if a therapy or a sampling is needed. Clear so far? Now, how do we actually prepare these patients? To be honest, in exactly the same as you would prepare a patient for flexible sigmoidoscopy. That's as simple as this. In some patients, you may want to have a full bowel prep if you've got a submucosal lesion or an adenoma or a polyp that you want to assess, or a sessile serrated lesion that you want to assess, because what you want to do is you would just want to treat them as you're doing a flexible sigmoidoscopy. Digital rectal examination, perianal inspection, get your patient in the left lateral position, do a sigmoidoscopy. Another thing to remember is, a lot of time we do the sigmoidoscopies even without giving any sedation, or in most cases just using a conscious sedation. But in this situation, if you are planning to do an endoscopy, sigmoidoscopy, and then going to do a radial and a linear scan, so you actually have to think, do I really need to consider either an enhanced sedation? Okay, or if it's a young patient, then you can get away with using the conscious sedation, where we may end up using a lot higher doses. So that's kind of the thought process. Okay, you know what you're doing, you know how your approach is going to be, you know how you're going to prepare your patient. So what are the examination steps? Again, just remind yourself, as you would do a radial examination of the esophagus, you want to keep the probe in the center, you want to inflate your balloon, you want to make sure that you've got parallel plane across the balloon. You want to advance it and advance up to 30 centimeters. So if it's only the rectal or anal ultrasound that we're doing, then we just don't need to actually go beyond the 30 centimeter. That's the plane that you need to scan. Unless this is a patient where we have a suspicion about doing an inflammatory bowel disease, then you can think about going into the sigmoid, but we're not going to be discussing that for the sake of discussion again. We can instill some saline or water to improve your visualization. That's something, again, which obviously air is an enemy, and as we've talked about, it's all about coupling, maintaining good views, endoscopic EUS views throughout the scanning. So probe in the center of the lumen, inflate the balloon, advance to 30 centimeter, instill water if you need to, and then examination is just actually performed. So we go up 30 centimeter and then gradually withdraw. On withdrawal, not going in. So rectum and then the anus. Another important thing is, as I said, I've seen colleagues who would actually put a band on the scope so that they can orientate where's the anterior and posterior. If your patient is lying on the left lateral side, it sometimes becomes difficult. What you should have is, I think you should always have some sort of imaging available. So in our rooms, what we have is we've got a monitor open and we've got the cross-sectional imaging, whether we're doing a pancreatobiliary or endohepatology or any sort of scanning EUS. We do keep the cross-sectional imaging right in front of us so that we can correlate what we're seeing. Here, because it's slightly different and it's not something that we do quite commonly, so you need to just orientate yourself. So you may want to have an image on the monitor which is accessible or seen, or an iPad if you have access to it, and then you just want to sort of orientate in yourself in that patient position, especially if the patient is lying on the left lateral side. So again, this image, as if you are, when the patient is lying in this position, where's your probe, anterior, posterior, left, right, which side are we looking at? And then having an cross-section imaging should make some sense. So whether it's going to be the normal mode or the reverse mode should not make much of a difference, again, depending what position your patient is lying in. Remember those layer differentiations of two black layers, which are the muscle layers. Outside one, as we know, is the muscularis propria. It may not be projecting very nicely. And then the muscularis mucosae. Those are the two layers. We just want to look everything around it, because sometimes you may end up sort of confusing the interface of the probe with the mucosa. But identifying those two layers essentially helps in most situations. The problem is, because the difficulty I think we have is because if that wall layer differentiation is lost, then you actually can't differentiate between an inflammatory and a malignant process. And that's why we have to do an endoscopic examination and a sigmoidoscopy of all the cases of rectal EUS. Because we know that the IBD or inflammatory bowel disease is going to appear different from somebody who's got a cancer, or a flat or a sessile serrated lesion. So keeping the same essentially concept. Now, if we then have to sort of orientate ourselves, if we end up doing the linear examination, again the same principles. Just work around those two black layers, muscularis propria and muscularis mucosae. Okay? Now, as I said, I know we don't want to do this station-based approach, but in some situation it does help. You know, as I said, going up to the 30 centimeter and trying to divide the rectum from upper, middle, and lower rectum, and then anus. So you can essentially say 1, 2, 3, 4, or 1, 2, 3, 4, whatever way you want to do it. But you can actually divide it into the 4 stages or stations. For rectum 3 and for anus 1. And then starting from the 30 centimeter and then coming back to the anal canal up to the 5 centimeter. So at the 30 centimeter, obviously starting off, you know, the vessels tend to, again, like the way we would do with the esophageal ultrasound, you would want to look at the aorta at the 6 o'clock position, because it helps you to orientate. Waveform Doppler, is it really going to make a massive significant difference? I don't think, but at least it just tends to orientate in terms of especially the staging of the disease, if there is a lesion which is involving the vasculature. Whether we're looking at the aorta IVC or the sacral brim, which may be slightly different in patients compared to those who have inflammatory as opposed to the malignant disease, where you can see differentiation between the left and right common iliac arteries and then left and right common iliac vein. So based on the waveform Dopplers, you may be able to differentiate this. It's all about pattern recognition. As I said, you know, we talked about the liver the other day. So one approach could be you want to just orientate yourself with what you're seeing on the cross-section imaging, or you can just ignore that completely and say, look, I'm just going to focus on the pattern recognition on the EUS images completely alone, which is fine at the beginning. How much rectal or endoanal ultrasound we'll be doing in the future? Different, but again, keeping a workable plan of how or what structures are major structures that I'm going to begin identifying when I start doing the examination. I've got a plan, I've got the patient preparation, I've orientated the patient lying in a certain position, I've looked at the imaging. Now, these are the few structures that I'm going to start off with. Simple to begin with, you know, from the right to front, public, pubis rami, bladder, ureter entering into the posterior laterally into the bladder, and then the seminal vesicles afterwards in male patients. It's a gray structure, to be honest, as I said, not something which I would be able to differentiate confidently with a node, but we don't tend to see many nodes in this region. Therefore, if it's elliptical structure that appears, it is the seminal vesicle. So sometimes you have to remind, where is the scope? Where am I looking at? Okay, I'm not going to find the nodes in this region. Therefore, if I'm seeing this elliptical or a triangular structure, it is the seminal vesicle. Okay. Again, with the prostate, sometime it may give you the false appearance of a cortex and medulla, because the center is going to be more aquabright as compared to the halo around it. So it may give that beam kind of structure. That's how I tend to do it. So if it's an elliptical structure, seminal vesicles, if it's appearing like a beam in this situation with the radial ultrasound scan, I know it's the rectal ultrasound scan. I know this was a male patient, and I'm going to see the prostate in this situation anteriorly. Okay, so just reminding of what I'm doing, which patient it is, and how then I have to look at it. Now, the important thing, obviously, as I said, is the two modalities that we're briefly differentiating: inflammation versus a malignancy. Starting off with the endoscopic examination and seeing where this peritoneal reflection is, and how do we kind of, on endoscopic examination, defines it. So when you feel the first and the second fold is, that's kind of the peritoneal reflection moves away from the rectum. Rectum is retroperitoneal, but that's where the peritoneum sort of comes in and starts to cover it, which is the junction of the rectum and the sigmoid. This is about sort of 7 to 8 centimeter from anal verge, or maybe longer, up to 15 centimeter, and it's the middle rectal fold, which is sort of the between the upper and the lower rectal fold, because above that is the sigmoid we start to see. Now, difference in the female patient, because the prostate is more like a bean-shaped structure, whereas the uterus that you're going to see, it depends on what cycle the patient is in. Is it a young patient? Is it an old patient? Have they had a hysterectomy or not a hysterectomy? It may give that elliptical shadow, but it then tends to balloon away from us. So it tends to just completely merge, and you can't actually identify the boundary. Why is that? I don't know, but I think it's probably because of all the peritoneal bowel structure that may come in, and maybe because of the air. But that's where I tend to sort of struggle when I'm just trying to follow where the upper border of the ureter is. But it just, again, gives us a bit of an idea of what we are doing. So, important that we start off examination with digital rectal examination. Palpate this anorectal junction posteriorly, which may give this ledge appearance laterally. On endoscopy, we can't actually differentiate, or cannot actually see where this sort of sling comes in. And in the EUS is just kind of trying to focus. Maybe the next image will show where the puborectalis muscle is. Black muscle, more thickened compared to the muscularis mucosae, muscularis propria, and that's the way you can see it, but not definitively. Two areas to focus on, because they have clinical relevance, which helps us in differentiating. Hopefully the next slides will tell us. So the internal or the external anal sphincter. Internal will appear hypoechoic as opposed to the external anal sphincter. That's very brief, broad way of kind of looking at it and trying to differentiate it, because I think especially patients who either have a pelvic floor dyssynergia or weakness of the external anal sphincter, and problem with either fecal urgency or patients having fecal incontinence. That's those areas where you can actually see, is it something we can help our patients or not. But I think this is a slide which I feel is quite helpful and useful, because you then have to see what age patient I'm scanning it. Is it a younger patient? Is it an older patient? Internal anal sphincter does appear hypoechoic, but with the increasing age, it may get more thickened. But if it's more than 4 millimeter, again, a very broad, kind of a very subjective figure, then you have to think about what sort of pathology are we dealing with. Is it just inflammation, or is it more than that? Whereas the external is hyperechoic and becomes thinner with the age. Hope it makes sense. Okay. Problem with the EUS, again, as I said, is sometimes it can over or underestimate.
What's CLL?
So external and internal anal sphincter. Ooh. Oh, okay. Yeah, so I think this the it will probably come on the next slide, which is some sort of ligament. I think it's a ligament. Can't remember the name. There it is, conjoint longitudinal ligament. So it's conjoint longitudinal ligament. Sorry, but essentially differentiating between external and the internal sphincter. This ligament. So conjoint longitudinal ligament. Hyperechogenic. Don't know. I think it's probably because of the perirectal fat around it. Don't know the answer. Khalvi asked why the external sphincter is hyper. I think it's probably because there's a lot of reflection because of the fat around it. I don't know, but I mean that's. Happy for you to look it up, Shanil, and if you can answer the question at the end. So we talked about this, puborectalis sling, looking at again, these different layers. So 1, 2, and 3. So again, this star was this CLL or conjoint ligament, and then the layer 2 and layer 3. So hyperechoic is the external anal sphincter, and the 1 is the 2 is the internal anal sphincter. So why is it? Question was why the external sphincter is hyperechoic? Because of the skeletal muscle composition. The ChatGPT says because of the skeletal muscle composition. Yeah, I mean, it says that because of the skeletal muscle composition. Okay, so the same. No, sir. So two images B and D, and again these are the kind of anal stationway starting from the puborectalis and then coming down. So on the B is you're looking at the perineal body anteriorly, whereas on the D we're looking at the perineal body anteriorly and this ligament again posteriorly. So B here, you can't see it there, can you? You can't see it on this. You can't see the pointer here. Yeah. So as I said, having a pattern in your mind of how to approach these patients, why we're doing it, what's the clinical utility, and a plan to approach, and then trying to identify, keeping it in the 3 rectal stations, 1 anal stations, trying to identify the organs anteriorly as posteriorly, slight difference only in the male patients in terms of what's anterior, posteriorly, the both remains essentially the same, coccyx, and then focusing on the muscle layer. So 2 things we're actually looking at. We're looking at the muscle, the mucosal layers that we all know. So that's an easy bet, because when we do the esophageal ultrasound scan, we can identify those 5 layers, which is the easiest bit. The difficult bit is slightly the organs that we're going to tend to see. But as I said, in my head, is the seminal vesicle is appears like a node, but no, in a region where there's no node. And then the ureter bladder, which may look like a kidney shape, but a kidney which doesn't actually seem to end one way or the other. And in the male patient, the prostate, which does appear like a kidney with a cortex and medulla, when it does not actually have a cortex and medulla. Okay, so that's the way, very brief way of kind of doing it. Let's just see the live demonstration that may help us to understand further. And the important thing is, in our practice, so the last 2 patients that I did before coming here, one was a rectal varices, and then the other patient where we did the collection drainage of the perirectal. That's it. which wasn't difficult to identify, easy to offer the therapy, and essentially had a clinical implication. So a lot less diagnostic and a lot more therapeutic. I don't think it has any role.
That's what I wanted to say. That's why if you go on if you look at on the net, rectal EUS, you find very few cases. In fact, normal demonstration is, the quality is really not there. So interventional radiology can substitute. We would have reduced this. How interventional radiology, in what way? Sir, like drainage of the mental side of that. Oh, yeah. They can do it, but वो कैसे access करेंगे? I mean, that's what I'm asking. But interventional radiology as we have progressed and evolved, so has interventional radiology. They're doing a lot of things. Again, for I'll tell you, because they have standards. But when I'm doing an amphilectomy, and I did one patient who had presented with bleeding, so we knew there was a big vessel. He came from Dubai, and we did an amphilectomy, and then when I had a discussion with the family, the patient bled after the removal, and I expected that, so we clipped it. I wasn't happy, so I asked the IR, this probably will need bleeding. They went, they couldn't see anything. There was no blood. So they came out. Patient bled 24 hours later. So went back again, and it was a very small vessel, but the clips actually helped them to go there exactly and stop. Again, by the time they went, the blood had gone. I said, I don't care yet. Put a coil in that area and finish that vessel. So IR backup is very useful depending on what you want to do or what you're doing, especially if you're worried about it. दूसरा हमने जो चीज नदीम ने टच की थी, नदीम आपने gastric variceal coiling and herpes.
No, I didn't talk.
We did talk about it. So, that is something that is obviously done a lot more now. I'm sure after Center when are you doing hysterectomy anymore or not?
Out of house, hysterectomy. So we divide it into two situations. Once they've had a hysterectomy and then they come back for the assessment, or if they present in ours, then we'll do an EUS. But out of house is mostly hysterectomy.
Assalamualaikum.
Can you hear us?
Yes, please. Ali, we can hear you and see you
Okay.
as well.
So go ahead and present the case, and then we'll start the rectal EUS.
Yes.
EGD की findings भी बता देना.
Colon.
Oh, I mean,
Yes.
flexi की findings भी
Yes,
बता
sir.
देना.
So we have a 75 years old female patient with history of altered bowel habits and bleeding per rectum for 3 months. Her CT scan and MRI pelvis are suggestive of a circumferential mural thickening involving the rectum and anal canal, and the maximum wall thickness is measuring 16 millimeter. There are enlarged lymph nodes in the there is thickened mesorectal fascia with enlarged lymph nodes. Along with that, some lymph nodes are also enlarged along the left external iliac, with the largest lymph node measuring 15 into 10 mm. The patient's colonoscopy was suggestive of an ulcerated lesion that was starting 5 centimeter above the anal verge, extending up to 8 centimeter without any luminal narrowing. Adult colonoscope was passed without any difficulty. Her CEA level is 2.07. So we are proceeding with EUS for evaluation of that rectal lesion.
Okay. So for rectal EUS, what usually I use radial scope. Radial scope definitely requires a balloon on that, and if needed, we can use a water, instill the water into the lumen of the rectum to have a better coupling if needed. But many times you usually don't need it. For the males, obviously, Nadeem gave a really good talk, the organs to look for, and it's very easy to identify those. The way I do it usually is I will bring the bladder to the top of the screen on EUS examination. So that gives me orientation at least anterior and posterior. So that's how we're gonna do that as well. Light on kar do. Okay. So the way I intubate is usually I ये इसका जो ना freeze का button नहीं है नहीं ये तो picture ले रहा है ना ये freeze का नहीं है okay so I usually how it कर लो usually I put the scope on my shoulder and then I freeze the button and like an endoscopic button before I go through the anal area. The reason I do that is I don't want if somebody people are watching, especially in the conference, just to be more respectful. I usually freeze the endo image into then go into the rectum, and then I usually will turn on. But in this case, there is no freeze button. Is there a help now? Okay. 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 ठीक है. Okay. So that's we have a really good endo image there, and they already have done flexic. I think it was mentioned by Nadeem that you really, for all these rectal lesion, do a good endoscopic examination before you do the PUS examination. Okay. So I will go as deep as I can. This is a which scope is this? A Fuji scope. Oh, okay. We'll go as deep as we can. Usually 15. With the radial, you can honestly go even deeper too than just to the
Khalid,
upper
did you ask
rectum.
about the system?
जी
आपने सिस्टम का सवाल किया था कि which
हाँ मैं देख रहा था कि ये फूजी है.
जी जी this is Fuji radial.
Is it a front camera?
It should be a front camera in the,
Yeah,
in the radial.
radial usually have a camera on the side, but this looked like it's a camera on the front. I honestly didn't take a look. It was on the front or side, but this is looks like it's in the front because it looks like an endoscope. But I think anyway we are. There's a lot of stools as well, so I'll start the examination right here and see what we can demonstrate. What I'll do is make the balloon big. You don't want to burst the balloon, but make it big enough that it's giving you a good apposition or coupling to the wall. And here, सक्शन को थोड़ा सा कम कर दो, सक्शन को कम कर सकते हो आप? ओके, कम कर, बंद नहीं करना, कम करना। अच्छा, ठीक है. So it was suctioning quite aggressively. So that's why I asked him to if he can decrease the suction. कहाँ पे है इसका ये वाला? Okay, system. Okay, इसको okay. Other thing what we can really do is like if needed we can put a water in there, but I'm gonna try to do it without water. There are some vessels I do see. What my goal usually is on rectal EUS to identify the bladder, and if in this case looks like that
Can we
black.
have the ultrasound image, please?
Okay. Image. अल्ट्रासाउंड का इमेज आ रहा है वहां पे? हाँ जी. ओके. So,
Yes, we have it. We have
okay.
it.
So here one thing what I did is like I completely collapsed the rectum. Wall is like coming along very nicely around the probe, and so I'm gonna just stick to that. Not I don't need to fill in with the water. If needed, we can put the water in there. But I think right now we're gonna be fine. But my goal is gonna be if I can find the bladder and bring that to the top. Right now there is another bowel lumen I see on the top, so I'll come back a little bit further down, see if I can find the bladder. You see the black structure on there on the top that looks like a bladder? Right there. Actually on the top right there, let me just make an image a little bit smaller. So इस पे वो देना जरा मुझे air. Okay, so press कर दो, ठीक है. So here, if you look at the, I made the image quite small. So the only reason I made it to show where the rectum is, you see the, not rectum, where the bladder is, you see the bladder right there. It's a black structure. So earlier it was on the side, you can do that as well. So that gives you a, like a, really a patient's position, the way they are laying left lateral, but I usually put it on the top. So that's the anterior part of the rectum. From there, I'll keep that on the top and then keep pulling back. And as soon as I start pulling back, in case of male, what you would see is before you reach the prostate, you will see those seminal vesicles. They are like a black pockets, black grapes, pockets different, and then just connected with each other. Irregular, when you put a Doppler on those, there is going to be really no flow on there. Here we see the bladder, and in this case, this looks more like a cervix or uterus, but I'll pull that a little bit back to get me an idea. This looks more like a cervix because it's a solid, you can see organ. And then I start coming back, it's going to disappear, and then you will see some air there. You see the air, and it gets collapsed. So that's vagina. It's just when it gets to that, it just gets collapsed, and you sometimes see air and there as well. So here is see right there, on there. Then there is a cervix there, and the bladder above that. So I'll keep coming back. Keep coming back. Now what I'll do is make the image a little bit bigger because we're going to pay more attention to the wall itself. Coming back, see a little bit, maybe if we need to put a water in there, we can. But at least I don't see anything, a tumor in there. One other thing I do is, if I gotta see one side of the wall, I will lean with the balloon on that side. Looks pretty good right there. I lean on the other side. Looks pretty good there. Now I can use the big wheel and the up and down and lean on the walls on each side. I have not seen any mass there, and even here, pretty okay. Don't see anything. We're getting actually close to the distal area, so I'll go back and look for that ulcer, rectal ulcer, and put the probe right on there and see if I find any wall thickness. So right there, we don't see a mass there basically. G. So it's right at the bottom. You see a little bit mucosal thickening, but the muscularis itself is really well preserved. There's some thickening of the submucosa, but I don't see any mass. I don't see any major lymph nodes, whatever we are looking at, honestly. So it's not does not look like a tumor or anything. So I think it's just the ulcer inflammation there. Right here, you see a little bit thickened wall itself.
Khalid,
G.
just as you were moving just now, did you see any small lymph nodes on
They
the,
were,
at
I
the
think,
6
at the
o'clock
bottom.
position?
Let me try again.
Yeah.
There may be, and even if they are, they look
They're not
very
significant.
benign. There were small, right there. One at the bottom, right here. Right there it is. And but they look so small. And you see the wall thickening a little bit there. And
Yes, we can, and it's
yeah,
very nicely
right
demonstrated.
here.
Thank you.
And it's I think it's just does not look like it's just the inflammation there. You see that there wall thickening nicely right there. And other thing that why I'm saying is like likely it's a wall thickening and inflammation around. Muscularis propria is quite intact there, and there is some inflammation around that area. But if you look at the muscle itself, it's quite nicely intact right there. Uh, all around basically, even all the way up here. So I'll pull that back a little bit. We'll go to the sphincters now, internal and external sphincter. What you do is for internal sphincter, you just basically follow the muscularis propria downwards towards the anal canal. You see it becomes a little bit thickened as soon as you get closer to the anal canal. It's all very nicely intact. Sometimes in fecal incontinence, you might see a break in the muscle, and usually that break is gonna be in females who have given childbirth. It may be a breakage on the anterior side on here, especially in those forceps assisted deliveries. Sometimes there could be a breakage in the internal sphincter on the top, and that and also episiotomy that could be leading to some breakage, and that would look like not a continuity of the muscle, but it would look like a fibrous strand there and breakage in the muscle. Overall, it looks pretty intact right there. So I think that sphincter is okay right here. It looks very intact. External sphincter, I know Nadeem mentioned about that, hyperechogenic. Most of the internal sphincter, which you really is going to see very close to the distal anal canal, where the internal and the external sphincters meet. When you get to that point, internal sphincter becomes a little bit more fuzzy on the outer side. And that shows that that's where the external sphincter is meeting. So I'll come back a little bit, come back a little bit, come back a little bit, and come back. We are almost getting out. You see that where it became a little bit fuzzy and there was a hyperechogenic area around that. Let me see if I can demonstrate one more time. Right here. Section थोड़ी सी आप ज्यादा कर दो. Okay, regular section. Okay, good. So you pay attention to the that muscularis propria, internal sphincter. You're gonna see that as soon as we come close to the distal anal canal, it becomes a little bit fuzzy and mixes with that hyperechogenic right. I'll freeze this image. Right in this area. Pay attention right here. There's gonna be another kind of a ring area. You see this area? This one right there, that is the external sphincter right here now. And they both mingle with each other and it becomes a bit more fuzzy when we get out. Right there, that's external sphincter. इसमें freeze नहीं होता? Okay, एक minute. So right here, you see that how it's becoming a little bit more fuzzy, and then it mixes with the एरो की तरह. Okay. Mixes with the external sphincter right here. एरो को हटा देना एक बार. Okay. And coming out, coming out. Okay, that's inside, coming, coming, coming. Right there, that's where it's meeting the external sphincter. Right there. Okay. We are already out of the anal canal. So, questions? मैं एक मिनट दे रहा हूँ मैं बलून को डिफ्लेट कर रहा हूँ ओके here it is. That was it. It's a very quick exam usually, unless you have to biopsy something or unless you have to drain, like a rectal abscess. Sometimes we drain that, or if there is any other lymph node or metastatic area, sometimes we look at the fistulas as well, and that usually looks like a breakage into the muscularis propria and ear in there. That's how the fistula looks like. So these are the basically, it's not rectal EUS for staging is not used much because I think MRI does a lot better job for the rectal cancer staging. But something needs to be biopsied, something needs to be drained. Sometime looking at the fistula, it could be very helpful. Okay.
Yeah, so, I mean, there's a question about fistula. Okay, in Crohn's disease and all, do you think, it would help classify the fistula better? Or, I mean, I personally think with
I can't hear.
I said fistula assessment
Yes.
with EUS. There was a question about that in patients, for example, in Crohn's disease. Can
Can you speak into the mic closer?
can you assess fistula,
Yes.
let's say Crohn's disease, with EUS?
I think it becomes difficult what you are looking at. If the fistula orifice, you see it clearly, you put the balloon on that, then you can assess that. I'm talking about the internal rectal fistulas. But other times, it can give you a clue. You have a nice fluid medium around your probe. Rectal wall is kind of compressed around that. You start pulling back, and what you are looking for is a breakage or a ear in that area, which is going through the breakage of the wall, and that's the only way. But it's not always really possible to, especially if it's a really, really small. It may not be very effective modality, but yes, you can look for that to get an idea where that is. Yeah.
If you have a good MRI facility available, then that's obviously going to give you a much better.
I'll come over there. Thank you.
Okay, thank you.
Thank you so much.
Thank you, Khalid. So that brings us to the end of our case, our cases. You've all had 5 cases hands-on. You've had repetition of different movements and what do you see with different movements? What are the stations actually that you should remember? Maneuvers that you do, movements that you do. I think that's been emphasized as much as it was possible. We've given you some talks about things that are relevant when you're starting, including FNA, FNB. So you've seen demonstration of FNA, FNA not really, but FNB, which is what mostly now is actually done. So had some very nice talks on different important aspects, whether it was liver, whether it is actually basics, se leke all the way. So I hope we have touched. There are a couple of things that we haven't touched, and just in brief. Now, most of your standard EUS diagnostic with FNB, FNA can be done with sedation. Okay. I don't know why, but like duodenoscope, because its scope is different, it doesn't irritate the oropharynx as much as the gastroscope. So patients tolerate it if you do it properly. Once the scope is down, they're not that bad with sedation. So it can be done. However, if you want to do any therapy, then I don't think you should do it without patient being under deep sedation, because you don't want them to move. That includes, if somebody is doing celiac, CPNs, or even difficult biopsies. If you think, I think the younger the patient, usually the more the less tolerant they are. So you just have to have some arrangement for that. All therapeutic procedures, especially pseudosis, ideally should be done under deep sedation. We don't do pseudosis without intubation. We don't. Okay, we only do it with intubation. The large pseudoses which are symptomatic, mostly those are the ones that you actually do. There's a lot of fluid that comes, and if you're not, if you're not intubated, that can obviously be aspirated. You've got patient under sedation. So that's something that I think is very important if one is going to embark on doing pseudocyst examination. So sedation is good for standard examination. Depends on what's available. We've had a little discussion on in our ERCP course, where you need to be careful. If you're going to give sedation, you must monitor your patient. You must have oxygen. You must have all the prerequisites or important resuscitation tools that are required. So all of those who are doing it in hospital settings, proper hospital settings, they all have this, so that's not a problem. But it's important to ensure it is your responsibility, and nobody else will be blamed. Something happens here, nobody else gets the blame. I get the blame. Okay, so it's my responsibility to ensure all those things are there. Tools are very important. There is no point, you go into a course, you go into a workshop, you think you can do EUSBD, and you start coming and you don't have all the things you need, you'll actually end up harming your patients. I think it's important to have all your things that you might need so that you start with that. Quickly do is we've got a model where you can actually puncture a cyst. We'll see how you find that model. So I need 2 volunteers, or we've got 2 rooms here.
There's no point going. I mean, you need to come closer and then we'll switch over to the hands-on. So, obviously, this is something that you've only done a few times. The concept here is मुझे आप कह रहे थे ना शीट निकलती है नहीं निकलती है नीडल जाती है आप कैसे अपनी नीडल को ऊपर नीचे करते हो all those can be done. You can inject, you'll get fluid, fluid wherever निकल आएगा. So this is like a cyst aspiration. That's what we are doing. We're working on other models, but hopefully in the next year. And on the body quality for that coming and observation water. And